Welcome to this animated lesson on neuromuscular blockers. We will explore their classification, mechanism of action, pharmacological effects, and clinical uses. Neuromuscular blockers are peripherally acting skeletal muscle relaxants. They reduce spasticity without affecting consciousness or voluntary movements. They act at the neuromuscular junction and are used as adjuvants to general anesthesia. Let us first understand the neuromuscular junction. The motor nerve ends at the muscle end plate. When stimulated, it releases acetylcholine into the synapse, which binds to nicotinic nanometer receptors on the muscle membrane. Neuromuscular blockers are classified into two main groups based on mechanism: non-depolarizing or competitive blockers, and depolarizing blockers. Non-depolarizing blockers are subdivided by duration. Long-acting drugs include D-tabacurine, pancuronium, doxycuronium and pipacuronium. Intermediate-acting drugs include vecuronium, atricurium, rocuronium and cisatricurium. Mivacurium is short-acting. Depolarizing blockers include succinylcholine and decamethonium. Succinylcholine has a very rapid onset and short duration of 2 to 5 minutes. Ideal for intubation. In the normal junction, acetylcholine binds 2 alpha subunits of the pentameric nanometer receptor. This opens the central sodium channel. Sodium rushes in, the end plate depolarizes, and the muscle contracts. Non-depolarizing blockers are competitive antagonists. They bind the receptor but have no intrinsic activity. They prevent acetylcholine from binding, so no end plate potential forms, and the muscle stays relaxed. A flaccid paralysis. Because the block is competitive, it can be reversed by anticholinesterasers like neostigmine. Neostigmine raises acetylcholine levels, which outcompete the blocker and restore transmission. Depolarizing blockers like succinylcholine mimic acetylcholine. They bind the receptor and open the channel, but they are not broken down quickly, so depolarization persists. This causes brief muscle fasciculations followed by flaccid paralysis. This is phase 1 block. With continued exposure, the membrane repolarizes but becomes desensitized to acetylcholine. This is phase 2 block, which resembles a non-depolarizing block and may be partially reversed by anticholinesterasers. Here is a quick comparison. Non-depolarizing blockers cause no fasciculations and are reversed by neostigmine. Depolarizing blockers cause initial fasciculations, have a much shorter duration, and are not reversed by neostigmine. Important pharmacological effects. Small muscles like those of the eyes and fingers are paralyzed first, while the diaphragm is affected last and recovers first. D-tabacurine releases histamine, which can cause hypotension and bronchospasm. Pancuronium and vecuronium cause tachycardia. Major adverse effects include respiratory paralysis, hypotension, asthma due to histamine release, and tachycardia. Succinylcholine can cause hyperkalemia, muscle soreness, and rarely malignant hypothermia. Clinical uses include surgical muscle relaxation as adjuvants to general anesthesia, facilitation of tracheal intubation, control of convulsions in tetanus and electroconvulsive therapy, and orthopedic procedures. Contraindications. All neuromuscular blockers are strictly contraindicated in myasthenia gravis. Caution in severe burns, hepatic and renal disease, lactation, and pediatric patients. To summarize, neuromuscular blockers act on nicotinic nanometer receptors at the motor end plate. Non-depolarizing agents are competitive antagonists reversed by neostigmine. Depolarizing agents cause persistent depolarization with initial fasciculations. The major risk is respiratory paralysis. Thank you for watching.